Greetings, I'm Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I'm pleased to welcome you to the multimedia summary for the journal's October 2023 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. Our editor's choice this month is an original article entitled Association of Mild to Moderate Aortic Regurgitation with Outcomes in Heart Failure with Preserved Ejection Fraction. It is authored by Dr. Christina de Kool from the Cardiovascular Center Ulst OLV Clinic in Ulst, Belgium, and colleagues from medical centers and universities in Naples, Italy, and Bulgaria. Heart failure with preserved ejection fraction is broadly characterized by symptomatic heart failure, an ejection fraction of 50% or greater, and diastolic dysfunction. Heart failure with preserved ejection fraction can be exacerbated by cardiac conditions, for example, atrial fibrillation, coronary artery disease, or non-cardiac conditions, for example, diabetes mellitus, chronic kidney disease. De Kool et al. Examined the prevalence of aortic regurgitation and its impact on outcomes in patients hospitalized with heart failure with preserved ejection fraction. Aortic regurgitation was either mild or moderate in severity, and heart failure with preserved ejection fraction was either new in onset or worsening in severity. The study population consisted of 458 patients with heart failure with preserved ejection fraction, with approximately 1/3 having coexisting mild aortic regurgitation, 1/3 moderate aortic regurgitation, and the remaining 1/3 without aortic regurgitation. Patients with aortic regurgitation had a similar prevalence of cardiovascular risk factors and other relevant comorbidities compared with those without aortic regurgitation, but the former group were generally older and with a lower prevalence of diabetes mellitus, obesity, and smoking. The essential findings in this study include the following. First, there is a relatively high prevalence of aortic regurgitation in this patient population. Second, this association appeared functionally significant, as the concomitant presence of aortic regurgitation was attended by increased left ventricle end diastolic volume index, increased left atrial volume index, and elevated left ventricular filling pressure at baseline assessment. Third, over the period of study, patients with aortic regurgitation exhibited an increase in left ventricular dilatation and a decrease in left ventricular ejection fraction compared with baseline values. Finally, aortic regurgitation of either severity was an independent predictor of all-cause mortality, cardiovascular mortality, rehospitalization for heart failure, and major adverse cardiovascular endpoints. In discussing the findings, the authors make the following telling points. The increased prevalence of aortic regurgitation in heart failure with preserved ejection fraction may stem from the fact that there are similar risk factors for both conditions, for example, age, hypertension, and diabetes. Such conditions may contribute to aortic regurgitation because of decreased aortic compliance or aortic valve calcification. Additionally, in the poorly compliant small ventricle that characterizes heart failure with preserved ejection fraction, the regurgitant jet may exacerbate left ventricular filling pressures and reduce cardiac output, thereby exacerbating pulmonary edema, exertional compromise, and overall outcomes. Finally, the present findings uncover a concomitant abnormality in heart failure with preserved ejection fraction, aortic regurgitation, that portends a worse prognosis in patients with heart failure with preserved ejection fraction. As such, this would obligate a careful follow-up of these patients with these dual abnormalities. The authors conclude by pointing out the need for prospective studies of these issues and by raising the consideration whether strategies that alleviate aortic regurgitation may lessen its adverse impact on heart failure with preserved ejection fraction. Our first highlight article this month is an original article entitled "A Nationwide Cross-Sectional Survey of Knowledge and Practices of Diabetes Drug Injection Techniques of Patients, Nurses, and Physicians, the China IT Improved Study." It is authored by Dr. Lixin Guo from the Chinese Academy of Medical Sciences in Beijing, China, and colleagues from several Chinese universities and hospitals. The prevalence of diabetes is increasing globally, and the country with the largest population of diabetic patients is China. Appropriate management of diabetes is critical in reducing diabetic complications, and such management often includes the injection of insulin and, more recently but much less commonly, the injection of GLP-1 receptor agonists. Guo et al. Undertook a highly important and instructive nationwide cross-sectional study of diabetic patients, specifically assessing their knowledge and practices of diabetes drug injection techniques. Importantly, the knowledge of these issues by managing doctors and nurses was also evaluated in their study. The study involved primary, secondary, and tertiary hospitals geographically situated across China. The study employed the Diabetes Drug Injection Knowledge and Practice Questionnaire for patients, physicians, and nurses. A questionnaire based on previously employed established questionnaires as well as guidelines from various societies. The questionnaire was administered between November and December 2020, and eligible questionnaires were collected from more than 10,000 patients, 2,800 physicians, and 2,600 nurses. The vast majority of patients in this study had type 2 diabetes, and the mean duration of diabetes was 7 years. 72.8% of patients use an insulin pen with pen refill and needle for injection, while 22.5% used a pre-fill insulin pen plus needle. 2.4% used the insulin pump, and 0.4% used needle-free syringes. 655 patients received the GLP-1 receptor agonist. Overall, 78.2% of type 2 diabetes patients did not achieve the target hemoglobin A1C. Hypoglycemic episodes occurred in 19.8% in the prior 6 months, and lipohypertrophy occurred in 34.7% of patients. Poor glycemic control was significantly associated with inappropriate practices such as needle reuse and incorrect injection site rotation, and with lower education levels. More than 70% of patients reuse needles, a practice based on attempts to curtail cost, their convenience, and their erroneous belief that such practices were not proscribed. In this patient population, physicians and nurses were the dominant sources for patient education regarding diabetes drug injection, whereas such education was much less commonly derived from friends and family members. Notably, almost 50% of physicians and more than 20% of nurses had poor knowledge domain scores. Our second highlight article this month is an original article entitled "Using Augmented Mean Arterial Pressure to Identify High Mortality Risk Patients with Moderate Aortic Stenosis." It is authored by Xiaoju Chao from the Department of Cardiovascular Diseases at Mayo Clinic, Scottsdale, Arizona, and colleagues from Mayo Clinic in Rochester, Minnesota, and Jacksonville, Florida. The message of this timely and well-done study is important. It underscores that diabetic patients who require diabetic drug injection are fundamentally responsible for the management of their disease. When such management is suboptimal because of a lack of compliance with established practices, poor glycemic control, and other diabetic complications occur. A substantial basis for poor compliance in this study is inadequate patient education, in large part due to inadequate knowledge of the responsible educators themselves, namely physicians and nurses. Finally, as the authors point out, their present findings provide the basis for national guidelines on this critically important issue of patient education. Aortic valve replacement, either by surgical aortic valve replacement or transcatheter aortic valve replacement approaches, is recommended for those patients with aortic stenosis with severe symptomatic disease. However, there is evidence that certain subsets of patients with even moderate aortic stenosis may have an increased risk of mortality if aortic stenosis remains uncorrected. Chow et al. Previously provided evidence that augmented mean arterial pressure, an index recently introduced by their group, is of prognostic value after transcatheter aortic valve replacement for aortic stenosis. This index requires the input of three variables: the mean aortic valve gradient assessed by echocardiography, systolic blood pressure, and diastolic blood pressure. This index can be calculated at the bedside. In the present analysis of almost 5,000 patients with moderate aortic stenosis seen at Mayo Clinic sites from January 1, 2010 through December 31, 2020, and followed for over 2.5 years, the authors examined the association of augmented mean arterial pressure with all-cause mortality. Notably, over this time period of follow-up, 36% of patients died. Using a cutoff value of 80 millimeters of mercury, Chow et al. Divided patients into those with high and low mean augmented mean arterial pressure. On multivariate regression analyses, an augmented mean arterial pressure less than 80 millimeters of mercury was independently associated with all-cause mortality, and overall augmented mean arterial pressure independently associated with all-cause mortality. Notably, the performance of this index was superior to an index also prognostically used for aortic stenosis, that is, valvulo-arterial impedance. In discussing their important and timely findings, the authors point out that in moderate aortic stenosis, the higher augmented mean arterial pressure indicates better cardiac contractile function at rest to generate blood pressures against the fixed afterload. The authors also point out the utility of this index in discerning patients with an increased mortality risk and prior to the decline in left ventricular ejection fraction, and the value of prospective studies in further evaluating these important findings. You can access these highlights and editor's choice articles free of charge during the entire month of October. Please visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, where you'll find our online-only features and many news stories posted in the News from the Editor carousel on our website homepage that are based on articles published in Mayo Clinic Proceedings. You will see other free content as well as articles published online in press. You will also find links to our social media by clicking the buttons at the bottom of the homepage to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you will find full-length author interviews called Insights and our MCP 60 seconds video article synopses. Our website also includes our Mayo Clinic Proceedings issue summary and Author Insight podcast recordings, which are available from our website on the homepage as well as through iTunes. As always, we gratefully thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.